Thank you very much, Apostolos, for that introduction. Herete, is that the correct pronunciation? And it's an absolute pleasure to be here, and I'd like to thank the Hellenic Urological Association and INUS for providing an opportunity for me to be here today. So you heard from Professor Madusbacher about the ever-expanding role of neurourology. And from the sort of traditional neurological conditions, such as spinal cord injury and spina bifida, which were how the birth of neurourology, now we understand that neurological disorders throughout the neuroaxis, that the bladder can be involved. And of late, there's been an ever-growing increase in neurodegenerative conditions. You heard about Parkinson's disease, and also in dementia. And so this talk will be really focusing on the problem of LUTS and dementia, and also sort of strategies to management. So if we look at patients with dementia, clearly the rates of incontinence are much greater than age-matched sort of controls. So this sort of data is actually epidemiological data from a large database in the United Kingdom. And the shaded squares represent patients with dementia. The ones that are unshaded represent those without. And as you can see that in each age group, you can find that the rates of incontinence are much greater in the group with dementia compared to the ones without, both in men and in women. And if you look at the initiation of pharmacological treatment for incontinence, you will find once again that the ones with dementia, there is a greater rate of first use of an intervention for the management of incontinence. What's slightly concerning is this third graph, and once again, showing between men and women, the ones in shaded are the ones with dementia, the ones without are not. You'll find that the rate of a prolonged use of an indwelling catheter is greater, statistically greater in patients with dementia than those without. So it seems that what the message is that dementia is common in the group with incontinence is greater in the group with dementia, that perhaps treatment is initiated, but very soon these patients end up with an indwelling catheter, which is probably one of the worst things that can happen in the time course of a patient with dementia. Now, not all dementing illnesses are Alzheimer's disease, and you will be aware that there are many degenerative conditions that can cause dementia in addition to Alzheimer's. Today's focus is on Alzheimer's, but you have vascular conditions, vascular dementia of infections. But in all of these conditions, if you look at it from a uroneurological perspective, these are essentially suprapontine lesions, or lesions at the level of suprapontine. And so without going into sort of the pathophysiological correlates in neurourology, just to explain that, so essentially this sort of group of patients, there's sort of an uninhibited detrusor contractions, which results in detrusor overactivity. And this group of patients will present predominantly with storage syndromes, so urgency, frequency, incontinence, nocturia. They have a synergistic coordinated activity between the detrusor and the sphincter. And so there's very little with regard to voiding dysfunction, and the post-void residuals are usually normal. So there is clearly dysfunction that occurs as a result of the lesion that in the neuraxis as a result of the degeneration in Alzheimer's disease. But it's not just the dysfunction that occurs that can account for the LUTS in these patients, and it's quite important to recognize that there's more to it when the patient with dementia comes to you with lower urinary tract symptoms. Now, there are actually differences between groups of dementia patients, and in this study from Innsbruck that Professor Madusbacher was senior author on, comparing different groups of dementia, what you'll find is that in the groups of patients with Alzheimer's disease, patients with Parkinson's disease with dementia, and patients with a condition called dementia with Lewy bodies, you'll find that there's a higher percentage of patients with this condition of dementia with Lewy bodies who present with urinary urgency, have urgency incontinence episodes. And if these patients were to undergo urodynamics, you'll find that significantly more number of these patients had detrusor overactivity in the urodynamics. So you might be seeing more patients with Alzheimer's in your clinics if there's a dementia patient, but it's this group that you need to be liaising with your neurologist and asking your neurologist, what are you doing about the incontinence? Because this is the group where actually the incontinence is much more greater. So, and it's not just the lesion that's important, but in dementia, there are complex neuropsychiatric changes that occur. And this contributes to a patient's presentation of incontinence. So, it's not just the patient becoming incontinent, but there is sort of a behavioral correlate to this. For example, the patients who have dementia have an impaired ability to initiate tasks in response to a stimulus. So if they perceive a sensation of urgency that would prompt you and I to go to the toilet, or at least a sensation for the bladder, individuals with dementia have an inability to initiate the task, and there's a delay for them to actually initiate the task of going to the toilet. It's not just that, but their coping strategies are impaired because of the neuropsychiatric changes. So as you and I, if we have a sensation of a full bladder, we cope with that differently, whereas a patient with dementia is unable to cope with this, and they become incontinent sooner. And also, as part of the dementing process, there's an impaired awareness of visceral sensations and external sensations as well, of sensations of bladder fullness, but also incontinence as well. So the patient with dementia who has incontinence is actually different in their incontinence compared to the patients without dementia, and these sort of behavioral changes need to be borne in mind. Now, it's not only that, but also patients with dementia can have several comorbidities that can be contributing to their LUTs. And so as urologists, you're aware about the common causes for incontinence. You heard earlier from Charlampos about functional incontinence, because many of the patients with Alzheimer's, as they progress, they also develop degrees of disability, motor disability as well. They're unable to reach toilets on time. And so they have a degree of urinary urge, but because of problems of the mobility, they don't make it to the toilet on time. However, what's also important to recognize is the cognitive impairment. And there are quite complex cognitive dysfunctions that occur. So, for example, visual spatial disorientation. So everyone in this room knows that the exit is there. Now, a patient with dementia who has visual spatial disorientation will not recognize that that is the exit. So in their room, if there's a door to the toilet, they will not recognize that is a place that I have to go to urinate. The patient perceives urge, needs to go to the toilet, becomes confused because they don't know where to go, they become incontinent. Visual spatial disorientation is one of the earliest and profound dysfunctions that occurs in Alzheimer's disease. You heard previously about aphasia, so patients are unable to communicate their needs. So if they have a strong sensation that need to pee, or if they're urgent, they're unable to communicate the need. Perhaps that they don't perceive that sensation as well. They have poor memory, so if they've been told what they should do, if they have an urge to urinate, for example, using a jug, they will forget this, they will become incontinent. Some patients with dementia have complex behaviors. So the carer or the patient will say that I actually frequent the toilet 10, 15 times an hour. If you ask the carer to follow the patient into the toilet, some of these patients will actually visit the toilet, do nothing, but just come back out as part of a complex motor stereotypic behavior. This is not urinary frequency, but it's a behavioral tendency. Some patients have social disinhibition, and so they just become incontinent just because of the loss of the social needs. And some patients have apraxias. They have an inability to perform complex motor tasks. So whether you and I would be able to unzip ourselves and go for a pee, these patients become confused because they're unable to perform that task. So these are all areas that will not be treated with, cannot be managed with an antimuscarinic or any of your treatments, but rather it's involving different respective therapy services to address these. And this is why when a patient with dementia who comes to your clinic with LUTs, it takes a little bit more time to recognize why the patient is becoming incontinent, because many of these sort of non-pharmacological interventions might help in a great deal in managing the incontinence. And of course, it's the numerous comorbidities. So I don't need to tell an august audience about urological causes that could be in the patient with dementia, which could be contributing to the LUTs. The patients might be having ankle swellings, so the patient goes to bed at night, the ankle swelling gets reabsorbed, the patient has nocturia. If they were to do a bladder diary, you might find nocturnal polyuria, and the cause is because they have ankle swellings, and it's more often a medical cause that has to be managed. The patients might be having other medical conditions such as diabetes mellitus or congestive heart failure that in their own right can cause problems with an overactive bladder or nocturia. Now, many of the patients are on medications. So for example, a diuretic for their high blood pressure, for example, this may be driving their urinary frequency and urgency, and in some patients, they go off the edge and they become incontinent. And of course, the story about the cholinesterase inhibitors that I'll be coming to in a few slides down. Now, sleep disturbances, so the patients with dementia, some of the dementing illnesses have very bad nightmares. They have a condition called RBD, which is where they lash out at night, especially with Parkinson's and dementia. So these patients are up because because of their sleep disturbance. So then they think, I might as well go to the toilet, and they go to the toilet and come back. So it's not an urge to urinate that's driving that nighttime frequency, but it's actually a convenience void. In which case, if the patient, you can recognize the nocturia being actually a convenience void, it's managing the underlying sleep disturbance that's woken them up in the first place. You heard from the ICS state-of-the-art lecture about obstructive sleep apnea, an important cause for nocturnal polyuria, but a common cause for in patients of the elderly. And of course, these patients can have other neurological conditions like small vessel disease. Now, it's very much a two-way relationship between dementia and lower urinary tract symptoms. So to summarize what's been said in the last few slides, there is definite neurogenic dysfunction, detrusor overactivity, that's the pathophysiological sort of correlate to overactive bladder symptoms in the patient with dementia. You have cognitive and behavioral changes, you have functional incontinence, you have medical and surgical comorbidities, and you have medications. And these can all contribute to the LUTS. These need to be factored in when you have a patient with dementia who comes to you with problems of incontinence. Now, it must be borne in mind, however, that the LUTS that the patient has can also affect their cognition and behavior. For example, if the patient is waking up several times at night, they have a poorly refreshed sleep, a disturbed sleep, their daytimes are going to be much more drowsy, and also their performance and their alertness is going to be much more poorer because of the nocturia. And if the patient is incontinent, if the patient has urinary infections, this itself will cause delirium and can make their cognitive status worse. And then antimuscarinics that you use. So medications are quite important in this group of patients because one medication that you start could actually tip them over into the worsening of cognition. And this takes me to the conundrum of acetylcholine. So as a urologist, your interest is to reduce the cholinergic activity in the bladder. As a neurologist, the interest is actually to enhance the cholinergic activity in the brain. And so you can see the potential conflict of interest that if we overlap our respective compartments, that then you start developing side effects. So how do we then address this conundrum, and how do we sort of manage the problem? So it is known that patients who take cholinesterase inhibitors, there is a risk for incontinence. Now, these are medications that ameliorate the cognitive progress or cognitive decline in patients with dementia. So patients with Alzheimer's will be having a cholinesterase inhibitor. This increases the acetylcholine levels in the brain and is supposed to help slow down the progression of cognitive impairment. But there are a few studies that have shown that there is a link between this because, of course, the medication is not specific for the brain. So you have increased acetylcholine levels in the bladder as well, which can contribute to problems with incontinence. And there are a few studies that you can read that have shown that there is an increased report of urinary incontinence in patients with the cholinesterase inhibitor, and that there are no significant differences between rivastigmine and donepezil. Now, the question that's always asked, however, is that if a patient were to become incontinent after their cholinesterase inhibitor, is it because of the medication, or is it because of the progression of the disease? Because incontinence can very well be part of the underlying a symptom of the underlying neurodegenerative condition. Now, this is a question that's extremely difficult to answer, and most often it's a history from either the patient who has insight into their problems, or from the carer or the spouse about the temporal profile, the time course of events that'll help you to ascertain what this is. However, this shouldn't be a reason for not giving patients this medication because the results are conflicting. And in a very large epidemiological study from the Netherlands, where they had a large database of patients who were given a cholinesterase inhibitor, it was found that there was no firm association between this treatment and the risk of urinary incontinence in the longer term. So it's very much an area of research that's required to really understand, one, is there clearly a link between cholinesterase inhibitors and incontinence? And number two, is how to manage the situation. So there's very little out there in the literature regarding guidance. However, the Dementia Working Group of the Neurourology Promotion Committee under Helmut Madesbacher at the time actually analyzed this question, and these were the guidance that came out in this very useful publication from earlier this year. And it's common sense if you read the guidance, but it's exactly what you would do as a clinician, is that if you have a patient who's about to be started, you would monitor the LUTs. So when the patient comes to you, you're aware that your neurology colleague is about to start rivastigmine or donepezil or galantamine, for example. It would be therefore monitoring the patient's LUTs, asking the patient or the carer to keep a diary over months to see the incontinent episodes, and that will tell you whether the incontinence, should there be a worsening of incontinence, could be related to the start of the medication or not. I would like to add that there is a non-cholinesterase inhibitor, so it works through a different mechanism of action called memantine, and this is an alternative in a patient where the bladder problem is significant and where some medication is required for the memory impairment. Now, moving on to the other end of the conundrum, the antimuscarinic that you prescribe for the patients. And it is known that antimuscarinics have profound effect on cognitive functions. Even in young, healthy people who take oxybutynin, significant changes in their EEG patterns have been noted. And in fact, pilots in the United States who take oxybutynin are not allowed to fly. So it is known clearly that these medications do have effects. And in this study in the healthy elderly that sort of tracked patients who were given either darafenacin or oxybutynin or placebo, and were monitored using neuropsychological batteries, it was shown that there was a significant alteration or a drop in their performance in these tests in patients who were on oxybutynin compared to the placebo or the darafenacin arm. And in the paper, Gary Kay and their group actually make a statement in the discussion that the magnitude of memory deterioration in this group was comparable to brain aging of 10 years. So significantly a problem. And indeed, we know that there is a link, and patients are now aware that if they take an antimuscarinic, there is a risk that they can develop that there's a risk of developing some changes in cognition. And this sort of article a couple of years ago actually came out in the lay press. And many patients after this started to ring saying, should I be changing my medication? Because what this showed was that in a large population cohort in North America who did not have dementia, but who were given medications with an anticholinergic property, that their incidence of dementia later on was greater compared to patients who weren't prescribed an anticholinergic. There's lots of pros and cons about the study, which this talk does not go into. However, it does sort of raise the awareness about the link between anticholinergics and memory impairment. And this takes us to the concept of the anticholinergic burden. There are medications on this list that clearly are associated with a high anticholinergic effect. Amitriptyline, for example, tolterodine, for example. But then there are medications that you wouldn't associate with having an anticholinergic effect, like your SSRIs or ranitidine. And what happens is the patients are piled on one medication after the other, and when they are then given their antimuscarinic, they often then tip over to develop cognitive side effects. So there does exist an anticholinergic burden scale, especially which is useful in patients who have polypharmacy. And you have patients whose medications that can be classed according to the anticholinergic burden. So medications such as your ACE inhibitors, your cardiology medications, which are sort of have a score of 1, as compared to the medications that have an strong anticholinergic property, we have a score of 3, and you get a score for the patient. Mm-hmm. So, for example, if you have a patient with Alzheimer's who has cardiac impairment, you can see that if they're on isosorbide, warfarin, furosemide, and digoxin, that's 4 medications. Already they have a score of 4, and now they come to you for incontinence and you start them on an antimuscarinic. That's a 3, so that becomes a 7. So you can see how the score piles up when you start the medications. Now, it's been known that if the patient is having a high anticholinergic burden, there's an increased risk for cognitive impairment. there's impaired functional performance, and also, as you saw in the previous talks, there's MRI changes of brain atrophy that have been seen, and also an increased risk for mortality. So what do we do? So you can choose, if you think that the antimuscarinic is the first line that you should start, you can choose a medication that has poor permeability across the blood-brain barrier, so something that's hydrophilic, something that has polarity, something that's large molecular size. An example is trospium chloride. Another strategy would be to choose an antimuscarinic that has a higher affinity for the receptors and the receptors, muscarinic receptors of functional relevance in the bladder, the M3 receptor, compared to the receptors in the brain responsible for cognition, which is the M1. So a medication with a high M3 to M1 ratio would be darafenacin. This is, however, quite theoretical. The number of studies in dementia patients are limited. And as you can see, there are some studies that have shown that with propivarine and one with trospium in patients with dementia, that there was no significant worsening in cognitive functions. However, the numbers of patients involved in these studies were small. You could consider other options, alternatives to antimuscarinics, and as you heard from Helmut's talk, the evidence base for mirabegron in the neurogenic population is quite limited. However, it's an attractive option, and at Queen's Square we safely do give mirabegron in our patients, and we find that these patients cognitively do not decline after using mirabegron. Tibial neuromodulation is yet another approach, so by either percutaneously trying tibial nerve stimulation or transcutaneously stimulating the tibial nerve, potentially attractive options. This particularly I find attractive in the dementia patients because this is home-based neuromodulation. The patients can actually perform this at home, do not rely on having to come to a clinic to have their nerve stimulated. So in summary, these are the options that you could offer in a patient with dementia. You have antimuscarinics such as trospium and darafenacin, and non-antimuscarinic options such as mirabegron or tibial nerve stimulation that could be considered. So in conclusion, I would like to emphasize the point that LUTS is very common in patients with dementia. It's probably just the tip of the iceberg of patients that actually arrive in your clinic, but if you were to engage with your neurological colleagues, you will find that there's a larger group of patients out there where indeed the bladder problems are a significant impact on quality of life, and as urologists you would be in an eminent position to manage that problem. There is a two-way relationship between dementia and LUTS, and that's probably the best way to sell it to the neurologist, why these patients need to be assessed from your side. It is important to monitor LUTS in a patient who started on a cholinesterase inhibitor, and it's important to monitor cognition in a patient who started on an antimuscarinic. So thank you very much, and I'll just leave you with this slide.